Hi everyone, welcome to researchmd.com. Again, great presentation today. We're going to teach you all about solitary pulmonary nodule. My name is Pramil. Cheriyath. I'm a program director, internal medicine residency, transitional residency. I teach medical students and residents. I'm also director of research. Let's get into our subject. Okay, when you look at the definition, what is a solitary pulmonary nodule? Isolated radiographic opacity, spherical or well circumscribed, measures less than 3 centimeter in diameter. Just remember that 3 is the key number. Completely surrounded by aerated line. Okay, not associated with atelectasis, hilar enlargement, or pleural effusion. Okay, so definition: single small focal radiographic opacity, often detected. Usually when you do a chest x-ray, you found this nodule, and then you have to get a CT scan, then you will find it. Okay. So, what are the risk factors associated with it? Clinical risk factors associated with increased risk of malignancy. That's what we were about. When you have a nodule, I mean, not all nodules can cause malignancy, but you have to be careful. Like some of them will talk about it. Increasing age. Okay, if you have a history of smoking, you're high risk. Number of pack per year. Again, the more number of cigarettes you smoke, asbestos exposure, bad. Radon exposure, right? They get a lot of houses now have that's why I think when you buy a house or something, they make sure there's a radon check. I think frequently, if you're living in a house, and I recommend it, please check for radon in a basement level, because you don't want to get lung cancer. Radiological factors associated with the malignancy: increasing nodule diameter. Okay. Speculation, if there's speculation, there's high risk. Pleural indentation, and if it is located in the location, also important, if it is located in the upper lobe. Now, benign nodules, some of the nodules are like you don't have to worry, right? If there's not growth, if they remain the same size, like greater than 2 years, likely is benign. And then benign nodules can be diagnosed if it is less than 3 centimeter and exhibit one of the 4 benign patterns of classification. So let's look at what are the benign patterns. If there's a central nidus, there's laminated appearance, there's diffuse and a popcorn appearance. So all of this kind of characteristic of benign nodule. So remember that, okay? When you talk about malignancy, there is increased in diameter, there's speculation, pleural indentation, and upper lobe location. But in the benign nodule, when you talk about central nidus, laminated, diffuse, popcorn. So popcorn is good, okay? So when you look about the malignant nodule, let's look at it. Characteristics of this malignancy. We already talked about the nodule size. If it is greater than 20 millimeter, it have better. I mean, it's a higher chance of getting malignancy. Spiculated, irregular, lobulated margin, vascular convergence, dilated bronchus leading to the nodule, pseudocavitation, true cavitation, ground glass nodules, and partly solid nodules, and all of this are characteristic. This is the main thing you don't want to miss a malignant nodule, because the complications can high. So what do you do when you have, how do you approach when the patient comes with the solitary pulmonary nodule? First, you look at the x-ray. There's rounded opacity, less than 3 centimeter, and completely surrounded by parenchyma, no associated lymphadenopathy. First thing, always compare with the previous chest x-ray. If it is stable, no further. So when you talk about stable, means you have to be stable for 2 to 3 years, right? And then no previous x-ray possible, or increase in nodule size, then you have to do a CT chest to assess the malignancy risk, okay? Then the next one, you do the CT of the chest to assess the malignancy risk. Then you put into 3 categories. If it's less than 2 centimeter, and 0.8 to 2 centimeter, or less than 0.8 centimeter. So if it is less than 0.8 centimeter, newer lesion, they're smooth, and then you got low risk, like less than 5%, right? Intermediate risk is when 0.8 to 2 centimeter, greater than 2 centimeter, which already talked about, is a high risk. Corona radiata, spiculated, high risk. So those group in the greater than 65% chance of having malignancy, you go for surgical excision right away, okay? The other categories, then you have to look at the nodule size, right? If the nodule size is greater than 0.8 centimeter, you can do a PET scan, and then no suspicion of malignancy. You can do CT scan every 2 to 3 years. And if it is less than 4 centimeter, Then you can do like serial CT for like, grade 2 to 3 years and reassure the patient, and then kind of follow. So very less likely there was like less than 0.4 centimeters. So we got put the categories together. You can kind of read it on your own, see which one, nice diagram, what need to be done in each category. The main thing is if the nodule is greater than 2 centimeter, think about, you have to have surgical excision. And then if it's also between nodule size, greater than 0.8 centimeter, and then you have to think about like, PET screws, PET scan and the biopsy. There's like another option. Okay, just remember that. Thank you so much for watching. We'll be back with another presentation soon. Thank you.